It's really a pleasure and honor to be with you this morning. It takes me back to some wonderful previous visits I've had here at Stanford, thanks to Dr. Fernando Mendoza, who's joining us here this morning. I always like to be the reason that people get together to have some food, get to know each other, and to share camaraderie, because we never have enough time in our busy schedules and lives to do that, to actually get to know each other as human beings and to understand the reason that we do what we do. I want to talk to you today about something that journalists came and asked us at HHS, and that was, how bad does it have to get before you do something about it? And what they were talking about was the fact that life expectancy in the United States has been dropping not just since the pandemic, but for quite a few decades now. We've lost, over the last 25 years, a considerable amount of life expectancy. We peaked in 1977 as a nation and have gradually been declining, and then saw a huge decline during the pandemic that I'll talk about as part of this discussion. Now, as most of you know, people often talk about the fact that, well, medical care actually only contributes about 15, 20% to actual health of people. It's really about that social, economic, and political environments in which people are allowed to thrive and to grow. And it's also about all those kind of preventive things that we should be doing to maintain our health. I had an interesting discussion with a couple of astronauts a couple of weeks ago at the White House. And I asked them, well, one of them was a physician. And I said, well, what do you think healthcare should look like in space in the 24th century? And he suggested, you should just read some of those great science fiction novelists. They've got some great ideas. We're not going to get to the Star Trek, wave the wand thing, but there's some really wonderful ideas out there. Well, some of the ones I've read really require people to be much more independent about their care delivery, to rely on a great variety of different kinds of devices and new kinds of screening tools and other things. For example, radiation poisoning is a common issue in space. So in one science fiction writer has someone who sits in a chair that looks like a barber chair and sticks their arm in this ring, and it scans everything in their body and spits out a little patch, just like those anti-tobacco smoking patches. Stick them on there and good to go. And so, is that what 24th century healthcare looks like? Is that what you imagine 24th century healthcare should look like? My suspicion is that the human element was missing in that scene, and that the human element will continue to play a big role in what we do in the future. And that's obviously where you come in, and where your students come in, and where we all try to really understand how we in fact provide high quality care through human touch. What I'd like to talk about today is the fact that this decline in life expectancy is really about the crumbling of our healthcare system, because much of the premature deaths are preventable, and they're preventable by good quality medical care. Let me first tell you a little bit about the Agency for Healthcare Research and Quality. 35 years ago, Congress recognized that while biomedical science and investments in biomedical discovery were important, it recognized that there were two other lines of inquiry that had to be intersecting lines of inquiry with biomedical sciences. And it was a recognition that we needed to really understand how to make progress in medical care. And so part of that care aspect was about technology assessments. Today, we're really busy doing technology assessment in a variety of areas. Most of you who are, especially in Silicon Valley, are abuzz with generative AI and how it's going to change all of what we do and how we do it. And yes, it is going to change what we do and how we do it. But it's not new to medicine. We've in fact been using artificial intelligence since the 1960s. We were one of the first industries to actually begin to use it in a broad way. Just that people don't even realize that they're using it. And that every time we have a computational breakthrough, we're able to create new artificial intelligence tools that take us to another level. So we're now in the third generation, or depending on how you count, maybe fourth generation of artificial intelligence making its way into medicine. But the third line of inquiry is biomedical science, the first, technology assessment is the second, and the third is health services research. And health services research was a field that was developed largely in the 1960s by physicians and engineers, to recognizing that care delivery was about improving processes, improving protocols, improving a variety of ways in which we organize and deliver care. And that we in fact needed to use the scientific method to do that. If we didn't measure it, we don't know whether we're making progress. And so that whole mentality came into our management fields, both in the private sector and other industries, as well as in medicine and healthcare. And as a result, the National Center for Health Services Research and Technology Assessment was elevated to agency status 35 years ago to what's now the Agency for Healthcare Research and Quality. And it's through these intertwining lines of inquiry that we actually make medical progress. Unfortunately, we've largely invested as a society in the biomedical side, and so our biological understanding of the mechanisms has advanced tremendously, but we've been unable to advance that into the practice of care. And so recently I announced an effort at AHRQ to work with the states, because yes, we don't have a national healthcare system, as many people unfortunately in Washington often think. We actually have many healthcare systems, largely regulated by the states, the territories, tribal nations, and those are the real players in healthcare. For those of you who have not worked outside of California, there is a different world out there, and a different way you practice, a different practice style. And you can see that in the great variation in care, and it's part of the story I want to tell you today. But AHRQ was founded to really look at how do we improve healthcare. And we go about doing that by funding researchers to generate the scientific evidence. At AHRQ, we also fund the effort and recognize that any one study, even if it's a randomized clinical trial, doesn't hold the truth. But the truth is to be found in the body of evidence. And so we also engage in evidence synthesis. And that's what leads to, for example, our biggest client, the US Preventive Services Task Force, who uses the kinds of evidence synthesis that we do to make recommendations to the clinical community about preventive services. And we do that in a variety of other areas and fields. And then what I like to say is we turn that synthesized evidence at AHRQ into actionable knowledge. And by that, I mean, we turn that into tools and guides and other things that clinicians and healthcare executives can use to improve care. And we disseminate it, and we're expected to help organizations implement it. And so the health extension service that I just announced a couple of weeks ago will work with states to try to reduce the time from innovation to actual practice. Because right now, some studies suggest it takes anywhere from 17 to 20 years to go from an innovation to actually get it into practice. Well, by that time, everything's changed, right? So we really need to speed up the time from innovation to practice, but with the kind of assurance and that we get from the scientific method, by synthesis, and by agreement about what is truly actionable knowledge. The Affordable Care Act also gave us another charge, one that's even more daunting than simply thinking about improving healthcare for everybody. And that is to improve our primary care systems across our nation. That's a perhaps more daunting situation because as the healthcare market changes, the role and location and the organization of primary care becomes more complex, particularly as organizations like Google and other large firms make forays into trying to figure out how they can provide primary care. But you know more about that, being here at the heartland of the technology revolution. I like to tell people who don't know AHRQ that the Agency for Healthcare Research and Quality is to healthcare delivery systems, as CDC is often thought of for public governmental health systems. And that is to provide the research and development arm to that industry that the industry cannot do on its own because it operates largely on very slim margins throughout most of the country. Now, let me get at the heart of what I want to talk about today. And that is, I'm sure you've recognized this population pyramid. It's a pyramid that talks about what our population looks like between males and females of different ages. And the pyramid in the 1960s looked like this for the United States, which is a pyramid that characteristically is one seen, this shape is seen for a growing population, a population that's relatively young and has fewer older folks. The projection on the right, I guess it's on your right, is the population of the United States as perceived in 2060 at the time that this particular chart was made, which was in the 1960s. So that was our view, that we were going to become a solid column with, continuing to grow, but relatively stagnant as a population, except for at the top, where we're going to have a whole lot of older people. The story's a little bit different because in the 1960s, there wasn't this notion of diversity in our society. Diversity was fairly contained within very small segments of our nation in the current way we think about race and ethnicity. But today, projections are showing a slightly different story. These are more recent population charts that really show how our population is growing. And what you'll notice is that in this particular graph, you have Hispanics on the edges, Hispanic portions of the age groups. And what you'll notice is that up until about here up, it's a fairly constant piece. And we now have centenarians now identified as part of the growth. And that's that sort of big little bubble that was in the 1960s projection. But down here, at the 35 years and below, what you'll see is that there's a slight increasing portion of the population that is from the Hispanic community. And it's the growing component of the American society, which is what allows us to have this much more growth perspective in our population. So that we're not in the same crisis that many European countries are in that have negative growth or that have no growth. But what this means is that we have a very different view of what our population looks like into the future. Increasingly, the population is Hispanic. And so since we're here to commemorate or celebrate Hispanic Heritage Month, and we're also sort of leaning into the Native American Heritage Month, you'll see there's some comparisons, there's some issues that I think our communities share. Now, I wanted to share this chart with you because many people in California have a very different view of what the country looks like. So this is a mapping by county of the the prevalence of different ethnic groups in those counties. And this is the way the country largely looks. It still largely looks like a predominantly white community, except in a few states and in a few counties. You'll notice that there's a huge number of green in California, both in California, New Mexico, a little bit in Arizona, Texas, Puerto Rico, some little counties in Florida, up here in the Northeast, that are predominantly Hispanic. Well, it's no surprise in California, but it's a big surprise for lots of other people around the country. And unfortunately, the conversations often don't recognize this sort of balance, because here's where the conversations go. What's the second most prevalent groups in these counties? Any idea? If you guessed Hispanic, you're right. Right? So here's the picture. All the areas that we saw that were largely Hispanic, the second group are white non-Hispanic. And all the places that were largely white are largely Hispanic. Although in the South, they continue to remain largely African American. Although there's a considerable set of other groups in other countries. So the diversity begins to show up in our communities. And what does that really mean? It really means it changes the demand for the types of services that people need and want. When we saw the population pyramid, we saw that the Hispanic community was largely on the younger side. And so those needs for pediatric services, reproductive health services, and other services, preventive services, are great. And in other parts of the country, the white non-Hispanic community dominates. And so there's an increased demand as our population is growing older, our predominant population is growing older, for the kinds of services that people largely bring to clinics, which are increasingly dominated by multiple chronic conditions. This is just another way of saying what I just tried to say, or summarizing what I'm trying to say. Older populations generally tend not to be as diverse as younger populations. And those differences have huge implications for the way we organize and deliver services, recognizing the kinds of economic and market demands that are being placed on our healthcare industry. Now, let me get back to this life expectancy issue. The chart up here in black, the trend in black, is other industrialized countries. So there continues to be a relatively decent growth towards extending life expectancy. The small dip at the end in 2020, obviously, is the effect of the pandemic. But look at the effect of the pandemic in the United States by looking both at racial and ethnic group trends. Not surprisingly, we've talked for many years about the difference in life expectancy between the African American community and other communities. But what's new is that we finally had enough data to illustrate what was going on with the American Indian community, which lost so many years of life, lost that the average life expectancy down here is equivalent to the average American life expectancy of 1944. That's a huge crisis. But the same story took place in the Hispanic community. This blue line, Hispanics generally tend to have really long life expectancy historically, live long, but with more disability. But during the pandemic, the Hispanic community, as many of our colleagues will have seen in a JAMA piece that just was published this week, and in other analysis that was done earlier at AHRQ and elsewhere, the Hispanic community had a precipitous drop in life expectancy during the course of the pandemic. People ask, well, why was that? And you saw the distribution of the Hispanic community. What did states do at the outset of the pandemic? Any idea? Shout it out if you have an idea. This is participatory. No idea? Did anybody hear of essential workers? Did everybody remember that states decided who had to go to work and who could stay at home? And in the vast majority of workers in the Southwest, where we saw the predominance of the Hispanic community, we saw huge death rates, a huge spike in death rates during the course of the first 2 years of the pandemic, largely because those were the workers who were out there in the meat packing plants, the chicken plants, out in the fields, trying to make sure that the rest of us who were safely at home, or unfortunately some of us in emergency rooms bringing in COVID patients or taking care of COVID patients, had something to eat, could stay at home, could be safe. But that was the price. The price was to be found in the Hispanic community, the African American community, and the Native American community. The Native American community, to less to degree on the work issue, and more to the fact that they, like African Americans and the Hispanic community, largely live in communities that have very weak public health systems and perhaps even weak healthcare delivery systems, or have no relationship with their care delivery system. And so this story is one that begs the question, what can we do? And this is the question the reporter was asking me. How bad does it have to get before we improve our US healthcare system? Because during the course of the last 2 years, there have been exposés about hospital closures, about the spike in patient safety events that occurred during this period of time. I'm glad to say that we've recovered to some degree with regard to patient safety events. We're making slow but steady progress to pre-pandemic levels. But pre-pandemic levels were not great. Pre-pandemic levels, and even in some areas now, meant that 1 in 4 people who walked into a hospital were going to have something bad go on, and something bad happened to them, often leading to death or to severe injury. So we can do better, and I want to talk to you a little bit how we can do that. This is an analysis that the Commonwealth Fund put out recently that really looked at, I don't know if you know, but they on an annual basis look at and rate the performance of healthcare in the different states. This is the first time they actually looked at the inequities by racial and ethnic groups. And what you'll see is that the states are aligned by their performance. And not surprisingly, some of them perform quite poorly. But there's a great variation in the populations in those states and the care that they receive. The Hispanic community is this kind of yellowish, orangish color. I can't get the pointer to work for me here. That you can see generally tends to bounce around down here at the bottom. So what can we do? What can you do? What can our learners do to actually change the way we provide care and improve the way we provide care? So this is not an issue that is only found in one part of the country, as you can tell. It's an issue that affects every part of the country. I had a good chance to meet some of your colleagues who are taking on the diversity issues in our care delivery systems here at Stanford. And we now have ways, as I said earlier, unless we measure it and we know what we want to achieve, it's really hard to get to that goal of equitable care for everyone. And so a nice progress report and measurement report has been developed, largely by the support of the Commonwealth Fund, that I'm trying to share with folks, because I think it provides that kind of a metric that allows organizations and care delivery professionals to recognize, to validate, and to help set goals that they can achieve to improve the inequities that exist in our care delivery systems. So I'll be sharing that with your colleagues, and hopefully if there are things that we at AHRQ can help you do, we'd love to help you figure out how you can implement it. That was my part of my dissemination stage, and so we're now going to be talking about some of the tools and other opportunities that AHRQ brings to try to address this. This is just another way of looking at that chart I just showed you. Looking in this particular case at the deaths that result from that inequity. And what you'll notice is that each dot represents a state. The number of deaths obviously rises as the number rises. And you'll see that, I can't get this pointer to, there we go. The American Indian population has probably the largest variation, but also the worst possible outcomes in many states. Our AHRQ has engaged in an initiative this year to try to address this problem, working with the Indian Health Service, with urban Indian programs, and with tribal nations that operate their own healthcare systems. But the thing to remember is that all those systems operate within the state structures, even though, although IHS is a federal care delivery system, it still operates largely within the context of those states. The African American community, again, we saw are predominantly isolated, or not isolated, but concentrated in the South and in the Mississippi Valley areas. And not surprisingly, if we looked at which of these dots they are, those are the states. The Hispanic community is a little bit more spread out and has a couple of states where clearly we have opportunities to improve, but that means improving also areas that we know will also improve care for many other populations, because we really are increasingly in a dialogue between the needs of the young, which is the Hispanic community, and the needs of the old, which is largely the non-Hispanic white community. So how do we organize a system that deals with the issues of the young and working age, and also deal with the issues of older people? Unfortunately, the issue is that, as I said, Hispanics historically have always lived a longer life expectancy, but have always had more disability, and disability at an earlier age, largely because of their work. And so many of the kinds of issues that are seen and that are amenable to medical care are quite similar, because at least in my experience, I've never seen Hispanic patients who walk in with a single issue, but usually there is multiple chronic disease of one type or another. We're prone to diabetes. Unfortunately, this job has also made me a little more round than I used to be. So we have a tendency to have fat around that's not very healthy. And so there are lots of opportunities where the needs of both an aging older white population coincide with the kinds of care that can be delivered and that is necessary for a relatively young working Hispanic population. Now, at AHRQ, we are charged with monitoring the quality of care that goes on, and we make a report to Congress every year on quality improvement. And one of the issues is that not only did we see the variation in the performance of the systems, but we also see variation in the safety and quality of care that people receive, which is illustrated in the previous charts. But here is sort of a bar chart of how we've reported it to Congress. that continues to be quite a lot of variation in the quality of care that people receive depending on their racial or ethnic group. Not surprisingly, it's the same story. African Americans and American Indians have really the worst profile, followed by the Hispanic community, and then the Asian Pacific and non-Hispanic white communities. In November of 22, I brought together a group of leaders from the healthcare systems, largest healthcare systems in the United States, to meet with the secretary to find out what should we be thinking about? How can we help them bounce back from the pandemic? And during the course of that discussion with the secretary, healthcare leaders and patient advocates asked for two things. Can you guess what they asked for? They asked for investment in building strong public health systems in their communities. Because the vast majority of them said, look, we're not organized and set up and function in the public health world. You're asking us to do things we're not prepared to do. Our staff weren't trained to do. And we need to get back to doing what we do best, which is provide medical services, personal medical services. So the second thing they asked for was federal leadership in trying to get a handle on the spike in patient safety events, recognizing that care had suffered as a result of the pandemic for non-COVID patients. Analysis we did at AHRQ recently, well, it's not been a year, I guess, illustrated that the pandemic was experienced quite differently in different parts of the country. And in fact, many parts of that middle part of the country didn't think we even had a pandemic because they had very few cases in their hospitals, whether they're rural hospitals or even urban hospitals in the middle of the country. But the fact of the matter is, when there were COVID patients, when we were hit with waves of patients, care for non-COVID patients plummeted. And plummeted in some areas, so much so that it was quite alarming that you'd have anybody arrive there. Post-pandemic, we're seeing not only, while we're getting a handle on the patient safety issues, we're seeing, as most cases, if you push on the balloon on one side and you take care of it, it pops out on the other. And so what are we seeing today? We're seeing a very different crisis in our emergency departments. We're seeing a crowding and, more importantly, or significantly, boarding issue. How many of you have had patients who have been boarded in emergency department rooms for more than 24 hours? Yeah. When I ask this question around the country, everybody raises their hand. It's a huge issue and a huge problem. Most people think, well, it's just a throughput problem. It's not a throughput problem. There are a whole lot of other dynamics at play today that, yes, we've had boarding and crowding issues in the past, and we've been studying this at AHRQ for 30 years, and we've come up with solutions over the 30 years. But today, the issue is different. The dynamics are different, and we need different solutions. Last week, we held a emergency department summit to look at what some of those solutions were for the new dynamics. And I'm happy to say that there are some ways that I think we can make some progress on this and relieve the pressure that you experience in the clinic. But the secretary recognized that we were losing 200 people a day to medical error, and really charged AHRQ and the other agencies in the department to create a federal response in partnership with the largely private healthcare sector and our governmental healthcare delivery programs as well. The Department of the medical units within the military, as well as the Veterans Administration, have been great partners with us in our efforts to move the ball forward. Well, we created the National Action Alliance for Patient and Workforce Safety, really recognizing that what the healthcare executives were asking for was an opportunity to share evidence-based practices across the nation, because by and large, they had not had a forum to do that. To offer them tools and playbooks that would allow them to address various issues. And also, more importantly, to gain mentorship from other colleagues around the country who were being successful. We took advantage of the fact that prior to the pandemic, we developed actually a plan for how to address this that got lost because of the pandemic. And so we dusted it off, looked at it, made sure it was actually what we needed to do. And lo and behold, it was exactly what people were asking for and needed. And so I invite you to join the National Action Alliance. I invite your organization to join, and I think that you'll find great opportunities for learning and colleagues. These are some of the tools that AHRQ makes available. Some of our other brothers and sister agencies offer additional tools. AHRQ is curating all of the tools that are at least available from the federal government. And we've been doing this now for 35 years, so we're fairly confident that many of the tools that are right for today are actually helping solve many of the problems that we're experiencing. For those of you who want to stay up with current events and developments that we're doing at AHRQ or with the National Action Alliance, I invite you to join our website, to get our newsletter, and just to keep in contact with me. So thanks. I'm ready to take your questions and exchange ideas, and I'm so happy to be here with you.
Okay, thank you so much for that wonderful discussion. I know we have lots of questions online and also in person. I already see Dr. Martin has a question. Oh, hold on a sec. We're gonna mic over to you.
Yeah, with people online, we often need those mic things.
So I'm a hematologist, and one question I have is whether AHRQ has ever designed the perfect hospital in terms of ratio of staffing, and not just RN to patient, but for the different types of hospitals, quaternary, tertiary, rural, subspecialist to specialist to RN, and that have you ever investigated what would be in the perfect world, what would be the ratio of that? And now that we could perhaps extend that, what networks could be to, say, assist a community hospital that might not have a consultative hematologist, for instance?
Well, I'm glad you asked that question, because we're getting the results that we've designed. And I've made a big push since joining AHRQ to get us to really re-examine the way we've even thought about patient safety issues. We, almost 20 years ago, the National Academy of Medicine put out a number of reports on patient safety and what we ought to do, and medical error became the term, and it was pointed at each one of you because you were making some kind of mistake. Often was the mentality, but in fact, that report, if you dig into it, also recognized that much of it was a systems issue. It didn't have anything to do with the clinical provider. It had to do with the context within which that care was being provided. And we never really took up that charge. At AHRQ today, we've taken up that charge in our work on patient safety to re-examine quality of care, not just in the hospital, because we no longer just provide care in the hospital. We have a whole lot of other delivery sites that weren't in existence even 10 years ago. So we need to think about quality across the continuum of care sites. And we need to think about how we actually design that care or redesign that care. And that's what we're engaged in now, including working with medical device manufacturers, similar to what we did with drug companies many years ago, to change the color of medications and the shapes of medications so that you could not get them as mixed up when you were prescribing them to a patient. We haven't done the same kind of standardization in engineering for medical devices. So, for example, you can have multiple different kinds of leads in the same operatory. You can have some of the things that people were facing during the pandemic was respiratory machines that came from different manufacturers, but had their knobs and dials in different ways in different directions that required you to know the machine as well as know sort of where you wanted to get it. So at least in our hospital, we had people who were accustomed to those machines. We actually had 2 floors, one with one set of machines, one with another set of machines, so that we wouldn't get the people's skills mixed up and asking them to do things that they weren't accustomed to doing. But it took a little while for people to figure out, oh, that's a problem. So, engineering and figuring out what is the right mix is something that I think is going to have to be dynamic, because we are in a care delivery system that is moving and changing rapidly. And so even our modeling of what is right today may not be right tomorrow. So we need to have a really dynamic way of thinking about how we organize and deliver. But it means we need to be much more flexible than we ever have been in the way we think about organizing and delivering services.
Dr. Mendoza.
Thank you for the great talk. One of the issues I'd like you to maybe address is when we categorize groups by these holistic names, Hispanic, for example, we don't identify the fact there's multiple cultures in that from different countries. There's acculturation issues, there are immigration issues, there are educational issues. And I guess I'm afraid that our system will not move forward if we don't understand the specificity of different groups within those groups. And clearly Asian Americans fit into that. I think Native Americans and even African Americans fit into that. What would you suggest to us if we're going towards the future, a greater diversity, of which actually this county is the most diverse county of all of California, which is the most diverse state? How can we at Stanford advance that issue, particularly as we think about AI and information?
Thanks for that question. It's a question that you and I have been struggling with most of our careers, because clearly when we talked about the health of Mexican Americans versus Cuban Americans versus Puerto Rican Americans back in the 1960s, when there were basically just those 3 groups, and they were very highly geographically concentrated. It was relatively easy for us to sort of make that distinction, with the exception of the Chicago area, where that was really where the sort of Latino community came together in the sense of a mixed group of national origin groups interplayed. But the real issue is part of the reason I showed you these demographics by county is that all healthcare is local. And so it's really more important about what your local healthcare systems understand about the populations they serve. And unfortunately, many of our medical records don't have these kinds of social classification labels. I hate to say this, but these labels didn't, in many ways, have complicated things internationally. During the pandemic, I was involved in a committee that reviewed the protocols for the vaccine trials. And most of the lead researchers for the pharmaceutical companies were people from outside the United States who had not lived in the United States. And so they didn't really understand these labels that we were asking them to increase the diversity of their study populations on. I hate to say it, but some of them even thought that they were biological markers or had biological significance, rather than recognizing that they were really social constructs that captured to a large extent the stratification and social and economic stratification in our nation, which is largely what they continue to do. And that notion that somehow or another these labels have some biological importance continues to keep scientists kind of at the forefront of this craziness. We don't have globally a way of talking about these social stratification issues that affect every community in the world. They just get measured in different ways in different communities. In the United States, we went down this trail because of our history of structural racism in an effort to legally sort of track whether or not people were receiving services that the government was expected to provide equally to people. And we've been trapped on the scientific part of capturing these variables and often using them in our research without really truly understanding what they mean in the context of where we're doing our research. Because that Hispanic label in Texas is quite different than the Hispanic label in Montana. And who are those people that you've labeled as Hispanic? Are they Central American Hispanics? Are they of Mexican origin? Are they Puerto Rican origin? Where are they? What is it that is part of that social and economic interplay that you as a clinician will have with your patient important for you to know about? And unfortunately, we don't capture that in many ways. We're making progress. Increasingly, there's been a recognition that we do need to understand that, but we're using these larger labels. And the federal government is actually going to be changing these labels to some degree as a result of a change in standards for reporting federally. But what you do at the local level and in your community and in your medical records are highly important for actually how you address this question that Dr. Mendoza posed to me. Because it's really about how do you understand the context, the social and the economic factors that your patients bring into the clinic and that affect them in where they live and where they work and how they live.
I'll take one question from the Zoom, if that's all right, because we won't get to all the questions, but we'll come back to the audience. This is from Dr. Stephen Ash. He says, thank you for the great presentation. As you said, much of the gap between what we could achieve in medical care and what we actually get is not a lack of biological knowledge, but an implementation gap. Recently, implementation science has been making great strides in incorporating this diversity perspective you championed in this speech. What can AHRQ or Stanford do to accelerate the targeting of implementation studies to reduce disparities?
Hi, Steve. Really great. Thanks very much. It's good to hear from you. Sorry, we're old friends. You always have great questions, and this issue about implementation is important. I think you need to recognize the difference between implementation science, which is what NIH created, which was to study how things get implemented using the scientific method. And they largely stop at the biomedical end of things. If you look at their implementation science roadmap, it kind of falls off the edge when it gets to actual care delivery. And so what we talk about in implementation, and we're actually talking about organizational implementation and clinical implementation, and not necessarily in that notion of let's study it. Let's actually do it. And if somebody wants to study us, that's fine. But let's actually get action to take place in organizations. And that really requires us to engage our healthcare executives more in the kinds of things that we think ought to happen. And unfortunately, we have largely stopped talking to healthcare executives. The clinical community often is doing one thing, and the healthcare executive community is often worrying about the finances and the bottom line and making decisions about the context within which clinicians operate or function, or making decisions about what resources are available for you to function. But we need a much more evidence-based management approach, which is part of the health services research history and agenda. And at AHRQ, we're trying to revive that and work more directly with healthcare executives. As you noticed, I tried to bring in the healthcare executives, first of all, to find out what is it that they needed and they wanted. And that's what led to the National Action Alliance, working with healthcare executives and clinicians to improve quality of care.
Dr. Stevenson.
Yeah, hi. Thank you, Dr. Valdez. Great talk. So I work in primary care. You mentioned the National Action Alliance, I guess, as an answer to one of the two things that the healthcare executives asked for when you brought them together, right? It was an answer to the, I guess, request for guidance on patient safety and how to sort of implement protocols for better patient safety. But there was something else they asked for, you said, which was better support for public health infrastructure. I think, I mean, you sort of, to paraphrase what you said, is that so that we can kind of get back to our jobs of delivering healthcare. To what extent, I mean, one, I'd be interested to hear what the sort of National Action Alliance for public health was, or if anything grew out of that request. And then second, to what extent do you see public health or population health as actually being a part of what we're responsible for as healthcare systems?
Well, the whole population health movement within the healthcare delivery systems was something that was taken up maybe 15 or 16 years ago as a recognized area because of changes in financing that attached the health outcomes of defined populations to defined care delivery arrangements. And that I think is an important aspect. In California, of course, you have a large history of organized delivery systems that take care of populations for long periods of time. So you don't have this churn problem that occurs in most of the fee-for-service plan offerings that most people have across the country still. The question of what have we done to build up stronger public health systems? One of the things that I think that's happened over the last few years is really a recognition of efforts at CDC to strengthen some of the areas that were identified as weaknesses during the course of the pandemic and also at the beginning of the pandemic. So some of the laboratory issues, some of the science that goes on for population services, some of the data monitoring, which became extraordinarily important for responding to the pandemic, have been built up. Many states, for example, in my state of New Mexico, where I was living, we relied actually on not the university to provide the data and to do the kind of data analytic work to drive policymaking or help policymaking. But we were blessed by the fact that we have two major national laboratories, one of which is often thought of badly because that's also where the atomic bomb was developed. But more importantly, they also have a very strong mathematical epidemiological capacity. And so they serve the state in that function, because in New Mexico, we largely have a state public health system and not a public health system that serves each county independently. In other states, you have hospital districts. In this state, you have strong county supervisors who act as boards of health. And so those decisions and those efforts take place really at the county level. So there isn't a simple answer. What I can say, though, is that some of the lessons that had to be learned at the federal level about where we were weak, where we needed improvement, have been moved upon largely by the leadership of the secretary and our new leadership at CDC.
Wonderful. Well, we are at time, so I will close this there. But thank you so much, Dr. Valdez, for speaking with our community and for everyone who's present in person and on Zoom.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.